Moving on to blood pressure and cardiac output. When you talk about blood pressure, you are talking about pressure within the cardiovascular system in its entirety. And clearly, as we already know, pressure in arteries is going to be much higher than the pressure that you find in veins. And arterial pressure is higher because we have to push a blood a far greater distance through relatively smaller vessels. You need to know the definition of blood pressure. It is the pressure exerted by blood on the walls of blood vessels. Please be able to spit that out verbatim. Clinically, you're talking about systemic arterial blood pressure because, again, we already know this, pressure that you're going to find within veins is insignificant. Mean arterial BP will rise to its max during systole and will fall to its lowest level during diastole. That should make sense. And we already know that the blood pressure within veins is basically non-existent. Insignificant would be a better term. Let me correct that. Normal BP, 120/80. If you have hypertension, you're going to have blood pressure that's greater than 140/90. And hypotension is abnormally low blood pressure. If you are an endurance athlete, you might have hypotension as a normal feature of you. Pulse pressure is going to be the difference between systolic pressure and diastolic pressure. There are a couple of really good spit that out. A couple of really good videos on how blood pressure works and what it is there. Please watch those when you have some time. If you think about the pressure of blood as it is shot through the aorta, you'll realize that, of course, that blood pressure is going to be highest in arteries closest to the heart, and right after that blood has left the heart. It is going to be lowest in the veins that are bringing blood back to the right atrium. Absolute pressure is not going to be as critical as differential pressure when you are looking at how to determine flow. So what are factors that actually influence arterial blood pressure? Cardiac output, we'll talk more about that in a minute again. Blood volume, if you have an increase in blood volume, you're going to have an increase in blood pressure. We've already talked a little bit about peripheral resistance. If you have vasoconstriction, you're going to have decreased blood flow. You will have, therefore, increased blood pressure, and you will have increased resistance. And then you have the opposite for vasodilation. Already mentioned cardiac output. The formula for cardiac output is stroke volume times heart rate. It is also, by definition, the volume of blood that is pumped through each ventricle or by each ventricle in a minute. Remember that the amount of blood in each ventricle has to be the same. About 5.25 liters in a minute for each adult. Cardiac output will be impacted by stroke volume and heart rate, those two components of that formula. How do we regulate blood pressure and blood flow? We already know about the cardiovascular centers and vasomotor centers within our friend the medulla oblongata. The information that is input to those cardiovascular and vasomotor centers come from higher brain centers, baroreceptors, which are going to detect any changes in blood pressure. Those guys are going to be found in both the aorta and the carotid arteries. Know those locations, hint, hint. As well as chemoreceptors, which are going to be scattered in various places, which will give you information about changes in important blood chemical concentrations, including hydrogen ions, carbon dioxide, and oxygen. When you talk about output, outgoing information, afferent information from those cardiovascular and vasomotor centers, you will have a couple of options. The impulses that are sent from the cardiovascular center will go to the sinoatrial node of the heart, and impulses from the vasomotor center will target smooth muscle of the arterioles. If you remember that about feedback systems, most systems in the body are going to be regulated by negative feedback systems. And here's another example of that. If your blood pressure is too high, that increase is going to be detected by those baroreceptors, which are, again, located in the carotid arteries and the aorta. That information will be sent to the cardiovascular and vasomotor centers, again, in the medulla oblongata. Know that. In the cardiovascular center, that will interpret that information and send signals to the sinoatrial node to decrease heart rate, which will lower cardiac output and therefore lower blood pressure. The vasomotor center will trigger vasodilation because information is sent off to the arterioles. When you have vasodilation, you have lower blood pressure. If blood pressure is too low, the opposite happens. We also have hormonal control because there are several different hormones that are going to impact your blood pressure. Some will act on the heart, which will alter the diameter of blood vessels or adjust blood volume. You need to know these hormones, of which we have already spoken. Epinephrine, norepinephrine will increase cardiac output. It will also trigger vasoconstriction. ADH, antidiuretic hormone, is going to increase the reabsorption of water in the kidneys. It will also trigger vasoconstriction of arterioles during diuresis and if you are hemorrhaging. Angiotensin II is going to overall trigger vasoconstriction of arterioles. It will also trigger secretion of aldosterone, and aldosterone increases sodium reabsorption in the kidneys. There are a couple of hormones that decrease blood pressure. There's atrial natriuretic peptide, abbreviated ANP, that will trigger vasodilation. It will also cause the loss of both salt and water through excretion of urine. And histamine causes the vasodilation of arterioles.